Warm welcome all of you. I'm Hemant and I will be reviewing today the root canal treatment that are taking place all over the world. What are the latest treatment protocols that are being followed all over the world, and what is the treatment protocol currently, latest treatment protocol that is currently being followed in India. The aim of this video is threefolds. I will be first sharing with you all the latest protocols that, as I said, all over the world and in India. Secondly, I will be comparing that protocol, the root canal treatment protocol, with the dentist that I had visited recently, maybe 3 months back, and I have been taking the treatment from her, and I will be reviewing where does she stand for doing this root canal treatment. Where does she stand in comparison with the latest treatment protocols that are being followed all over the world as well as in India, so that you can also compare your dentist with the latest treatment protocols that I will be sharing with you, and so you know where your dentist is standing and what is the scope of improvement. Thirdly, lot of my colleagues as well as doctors, be it MBBS, MDs, ND, DDS, and doctors all over the world, who are basically also want to do the root canal treatment but are scared for some reason or other, or just curious to know what are the latest treatment protocols and whether the dentist is doing the latest treatment protocols that are available or no. So for those reasons also, I have list of questions that are being asked to me by the fellow colleagues as well as doctors. So I have the list of set of the questions that I have prepared, which I received in past maybe 6-7 months. Those list of questions I have compiled, and I will be answering all those questions to you, as well as I will be answering the questions that have come across to me, which are being asked by the laypersons who are not doctors. So the variety of the questions that I saw, the concerns that I saw being asked by the doctors are different, and the concerns that are being asked by the laypersons are different. So what I will be doing is I will be dividing this video into two parts. First part will be dealing exclusively with doctors, but it doesn't mean that a layperson should not see that. Basically, you see that just to know what are the latest treatment protocols followed while doing the root canal treatment, so that you get an idea of where your dentist is heading, and whether your dentist is using this latest treatment protocols or no. So please watch that video even if you are in lay users, and the second part of the video will be exclusively for lay persons. So basically it's a combination of addressing the queries of, as I said, I will be addressing all the queries of the doctors as well as the layperson. The first part, I will be addressing the queries of the doctors, but laypersons also I request, please to watch the first part of the video also, so that you are really well aware of what your doctor is doing to you and whether he is following the correct protocol or no, so that you can basically judge yourself that is this the right person for you or no, or whether you have to change the doctor. Currently I will be reviewing the latest protocols. As I said, ideal case I will present in front of you, then I will be reviewing with the dentist that I had gone. The name of the dentist here is Dr. Preeti from Pune. She is practicing in Pune, currently located in state of Maharashtra in India. And then I will be comparing both the protocols, and in the meanwhile, while I'm explaining you all both the things, you can also compare your dentist with the things that I'm telling you, so that you know where your dentist is also heading, and whether there is any scope of improvement. That also will be helpful for you. So please do watch. Let's get started. So the first question that I get is, what is the concentration of sodium hypochlorite used by your dentist, that is Dr. Preeti, during the irrigation? Okay, so this is the first question. Obviously this is the first question, then naturally that will come up. I will tell you for the lame persons, I will tell you the significance of this question and why this question is of utmost relevance in the root canal treatment. So in root canal, basically what we do is we disinfect the infection that is taken place inside your pulp chamber in the root canals. So the things that are first, the most commonly and the most trusted disinfectant that is used for cleaning your root canal is sodium hypochlorite. The reasons for it is three purpose. The reasons for it is basically for the three purposes. First is for using as a general this one disinfection for killing all the microbes. Second is it kills the necrotic tissues also. So whatever the dead pulps is there, or whatever the residual tissue, dead matters, decayed matters is there, the sodium hypochlorite has an property to dissolve that decayed matters or necrotic tissues, and you can remove that properly. The third thing is, and basically the major factor is to kill the biofilms. Whenever you are doing a root canal treatment, this is the most important thing. First sitting, when you go to the doctor, whatever may be the sittings, whether it is a single sitting RCT or whether it is a multiple sitting RCT, the aim of the dentist here should be to kill all the microbes and to make sure that the microbes, that is the infection, doesn't come again. So for that reason, you have to kill the biofilms that are present inside your canals. And in order to kill that biofilms, the best way forward till now, which is medically proved and medically published all over the world, and the treatment protocol here is exactly the same all over the world, that is sodium hypochlorite. The sodium hypochlorite is basically the go-to solution for killing the biofilms. The only thing here is what concentration of sodium hypochlorite should be used. That is a question of debate. So if you go for an endodontist, or if you go for an proper dentist who has 15 to 20 years of experience, these people basically will directly go for 5.2 percentage of sodium hypochlorite concentration they will use. Basically they are much more reversed with the sodium hypochlorite, and they are more comfortable, while youngsters maybe who are freshers, they won't go for directly 5.25 percentage sodium hypochlorite concentration, because of getting worried about the sodium hypochlorite accident that is taking place, which can result into swelling of the jaws of the patients. So one approach is to go aggressively. One part of the dentist will go aggressively on 5.25%, and they will proudly boost themselves that I am using 5.25 percentage of sodium hypochlorite, and 1% will, and some class of the dentist will be moderate. They won't be too much aggressive, and they will basically what they will do is they will the other set of the dentist will have a cautious approach, and let's see which approach is much more better. So one argument for the endodontist, as well as the doctors who are using 5.25 percentage sodium hypochlorite, is there is one research paper that is published in which it talks about killing the biofilms completely by using the sodium hypochlorite percentage of 5.25 percentage. So that is basically the reason, driving force you can call, for which the endodontists are using 5.25 percentage NaOCl, that is sodium hypochlorite. But in front of one paper there are four different papers, also four different publications, prestigious, published in the prestigious medical journals also, which says that it doesn't have to have 5.25% sodium hypochlorite. So I will basically post the publications links also in the description below, and I will exactly as it is, without adding any words to it, I will just read it out to you what it is saying. Using multiple, I'm directly reading from the medical journal, okay? So using the multiple instruments like sonic activators, ultrasonic activators, high volume of NaOCl, and having longer retention time of NaOCl also does the work. So basically what it's saying is, for laypersons, what it's saying is, if you are using multiple instruments during the irrigation is during the cleaning, whenever you are cleaning your root canal with this sodium hypochlorite. So that is irrigation actually. So whenever you are using multiple instruments like sonic activators or ultrasonic activators, I will for the lay persons I will come to this in a bit. What is sonic activators and what is ultrasonic activators? I will be sharing with you some posts also, so that you are able to understand the differences. For the doctors I'm saying, if your dentist is going to use multiple instruments for during the irrigations like sonic activators or passive ultrasonic activators, and using the higher concentration, higher volume of NaOSCl, which is up to 40 milligrams, 40 ml, sorry, 40 ml of during the BMP, and is having the longer retention time. By the longer retention time, here in the medical journal, it is specifically mentioned that the longer retention time means NaOSL in placing the NaOSL inside the canal for 20 seconds has more better effects in disinfection than placing the NaOSL for 10 seconds. This is exactly what is mentioned in the medical journal that I am exactly reading as it is. So what it is saying is basically going for an 5.25% of NaOSL is also problematic in some cases because of the cytotoxic nature and the cytotoxic effect that it has on the radicular tissues. And I am again reading exactly from the medical journal. These are not my words, I'm directly reading. You must understand that going for the 5.25% of sodium hypochlorite also has a drawback of causing more pain post RCT treatment, and also has an effect of having cytotoxic effect on radicular tissues. So who is the better candidate for having 5.25% sodium hypochlorite? The correct answer for this is any person who is going only for a single sitting RCT. For the multiple sitting RCT, it's better to go on the lowest strength of sodium hypochlorite, and I will tell you how much is this thing that is advised. For ideal cases, let's go for the ideal case. Ideally 0.5 to 6% of sodium hypochlorite in US it's used ideally, correct. If you go strictly by medical literature, 5.25% is used for killing the biofilms. And then this third paper I quoted, which is saying that if you use 2% of sodium hypochlorite mixed with 17% of EDTA, use both things together. Just don't rely on one thing. Sodium hypochlorite combined with EDTA, 17% of EDTA, gives best results. And the cytotoxic effect that you see on the periradical tissues is also not observed, as well as the post RCT treatment, the pain that happens due to using higher concentration of sodium hypochlorite, that is also not visible. So key here is three things are key here. The volume of the sodium hypochlorite that you use, approximately 40 ml that you have to use during your full BMP procedure. Okay, full BMP procedure. Then longer retention time, that is 20 seconds, and then using different instruments like sonic or ultrasonic or PIP if you are using, or endovac if you are using. Make use of all those. For the lay persons, I will come to this what the instruments name that I have told you. For the lay persons, I will be explaining what these instruments I am talking about. So coming to the dentist now, with whom I had taken the treatment, Dr. Preeti. How much concentration does she use? She used the concentration from 2% to 5%, depending upon the patient's case. Each patient is different, each case is different, the infection rate in one patient is different, infection rate in the other patient is different. So whether to go for a single sitting RCT or a multiple sitting RCT, that question should be best left to your dentist. Let her take the call. Let her or him take the call whether the single sitting RCT is best for you or the multiple sitting RCT is best for you. Seeing your CBCT reports or your normal radiography, OPG scans reports, we can get an idea of how severe the infection is. Depending upon that, the dentist will directly tell you whether single sitting RCT is better for you or multiple sitting RCT. That is purely a domain of the dentist, and the dentist has to decide. Please do not pressurize the dentist saying that I have time, lack of time, lack of time paucity is there, I want to rush to this meeting, I want to go to trip, I want to go, for any reason whatsoever, and pressurize your dentist to get the RCT done in single sitting, or say in 2 sittings or 3 sittings. Please don't do this kind of things. The even in your in while prescribing the antibiotics for the patients, we give the antibiotics treatment for 5 days minimum, right? And then we hope that the infection gets cleared. If it's not getting cleared, then we rotate the antibiotic, we change the antibiotic, and then the treatment continues till the infection is gone. Same thing happens in dentistry also. There's nothing different, there is no magic formula. We in the first sitting we do the BMP, and in this BMP, first step is getting disinfected by sodium hypochlorite, and during that process, if the infection is too high, BMP is done, and then intracanal medication is put. And once that intracanal medication is put, then again we have to wait 7 days or 14 days or 21 days, depending upon the case, whether you have a low infection or a higher infection. Depending upon that, the doctor will take the call. Please don't get scared if the doctor tells you that this treatment will take 21 days or this treatment will get over in 15 days. Here there is no question of comparing your dentist here. I'll tell you one example. One patient, for him the dentist told that your treatment will take 1 month, and one dentist told, no, I can do this same thing in one sitting. So naturally, for a lay person who doesn't understand anything, he will think that, okay, in one sitting if my problem is getting solved, why would I go for 1 month long treatment? So but basically this is not the right approach. In one sitting, if the person is not able to solve the infection in one sitting, then you had it. You again have to come back for reroot canal treatment if the root canal failure occurs, and then the expense for doing that is twice. The reroot canal cases are more complicated, more difficult to resolve than when you have natural, not when you first time are doing this thing. So please have trust in your doctor. If he's saying or she is saying that it will take 10 days or say 14 days or say 21 days, please have that patience. Please don't pressurize your dentist, and go accordingly. So this is the first question. So then the next question is, how do you measure the working length? Do you use the apex locator? Do you solely rely on the apex locator, or do you confirm it radiographically too? Correct, good question. So in previously, when apex locators were not there, and even now, many dentists I have seen, they are not using apex locator because they don't want to make an investment in buying those or purchasing those apex locator. If you, for the normal users, for the lay persons, what is apex locator? Apex locator is, let's say this is the root canal, this is your opening of the root canal, this is your tip of the root canal, this is known as apex. That is the last point of your canal. So basically what happens is, if this is your canal, you have to disinfect complete canal. Now this I'm just showing you as a finger, but the canal is not straight this way, it's curvature also. In some canals it's too much curvature. I'll come to that case later. But basically what happens is, we have to find out the working length for putting that file inside your canal for doing that BMP. The first thing that I talked about, that is using sodium hypochlorite and then doing the BMP. That is biomechanical preparation. BMP is known as biomechanical preparations, in which that is the first step of removing the infection. So that for that thing, and basically finding the length of the apex is very very important. You don't want the infection to be getting cleared only till this point. When your apex is here, clearing the infection till here only doesn't solve the problem. You have to clean thoroughly entire canal, and for that you need to properly identify the exact length of this apex, and then 0.5 ml 0.5 this one size length is left out, and rest entire canal is cleaned. Why 0.5 is left out, again that I will tell later, or maybe I will make another video for that. So basically, but the thing is, you have to clean the entire canal till apex. That is the goal. And to clean the canal till apex, you need an instrument known as apex locator. This is the latest. Okay, this is the latest thing. And then there are the apex locator is also not one. There are first generation, there are second generation, now there are third generation apex locators. And even if you are using the third generation apex locator, it's always best practice for you to use the apex locator, clean this, and then confirm it radiographically also. So by this way you are doubly sure, you are making sure that your entire canal is cleaned properly, and you are having an accurate working length measurements. So this question, how do you measure the working length apex, and do you use the apex locator? Absolutely, Dr. Preeti does use the apex locator. That is the latest technology, and she does confirm radiographically also. And it's not confirmed once, it's confirmed twice, thrice also, till you get an exact working length measurements. So this addresses the second question. Third thing is, what are the different activators or the delivery system does Dr. Preeti use during irrigation or for disinfection? Okay, so I'll tell you the different delivery systems that are available in India first, as well as what are available in world. So, and then I will come to what Dr. Preeti uses. In India we have manual, that is using hand files. Then you have sonic agitation techniques. Then you have passive ultrasonic irrigations, PUI. Then you have negative apical pressure techniques, which is your endovac. Then you have laser activated irrigations, LAI. And then you have PIPS, that is photon induced photon acoustic streaming, PIPS. There is world of difference between laser activated irrigation and photo induced photo acoustic streaming, PIPS. Even though both techniques are laser based technologies for disinfection, both the technologies are totally different, and the outcome that we get from the treatment of using LAI and PIPS is completely different. It's a long topic. If you want, I will make a separate video doing the comparison of PIPS and LAI, that is laser activated irrigation, and PIPS, that is photon induced photo acoustic streaming. PIPS is the latest, and this is the latest treatment protocol that is available globally. And high end, almost all the high end dentists actually are now using PIPS. So it's very good. It's very good. I will make a separate video regarding PIPS and its importance. Currently I will just restrict to I just had, I will just restrict myself to sonic and ultrasonic. The reason being, the treatment that I'm currently getting from Dr. Preeti, she is using sonic and passive ultrasonic irrigation, so I want to talk more on that. And I will make a separate video on Endovac, LAI, and PIPS, and what is better, if you are interested to know the difference between them. So let's get started. So okay, for the long-standing infection cases, the more advanced technologies that we are using, the better are the results. Let's say, what is the difference between sonic and ultrasonic? I'll place an image, or on video I'll play an video, so that you will better understand what is the difference between sonic and ultrasonic. Basically, to sum it up, in the when the sodium hypochlorite is poured inside the canal, at that time, how much vibrations per second the instrument is able to generate, that is basic difference between sonic and ultrasonic agitators. And the more the vibrations the device creates inside the canal, the more your canal gets thoroughly rinsed by sodium hypochlorite. That is the technique. What, remember what we had told, we have to clean the canal entirely from the top till the apex. And for the sodium hypochlorite to reach till the apex, now this is the straight finger, but the canals are not straight, canals are totally curved. Sodium hypochlorite has to reach till the end, and then not only reach, we have to thoroughly rinse that canal in order to have that rinsing effect. For that reason, we have to use these activators, that sonic activators as well as this ultrasonic activators, and these are also latest. I have seen here dentists, even in Mumbai or in Pune, many people are still practicing hand files. Hand files is not bad, I am not against it, it's very good, it's excellent, but use proper agitators also. First, properly rinse the canal by using sonic or ultrasonic, so that you are properly able to generate that flow, that resistance, that you are able to properly get inside to thoroughly rinse that canal. Once that is done, then you can use the hand files. Then another thing is, regarding Endovac is high-end system. The reason, in Pune, to tell you precisely, only one center I have seen where Endovac system is used, and in PIPS, for PIPS also, in Pune there is only one center. Again there is only one center which is using PIPS, and whom I don't want to name the person, but you can properly go to PubMed and you can Google it, and you will know the proper name of the person. And even you can get the name of the institute that is using this PIPS technology. It's an high-end technology, it's very costly. In US I had seen that PIPS technology being used, it's very good. If you get it, go for it. If not, then even your sonic and ultrasonic is also much better. I have taken treatment from Dr. Preeti for past 3 months, and from personal experience I am telling you, whatever technology, whatever the limited resources that she's having, limited in the sense, not having Endovac and not having PIPS, despite of not having Endovac and despite of not having PIPS, then also for the crooked canals, she's perfectly able to rinse it exactly, till apex she goes. She cleans out everything, she doesn't let any residue to take place. She is doing excellent work, excellent, mind-blowing work. So seriously, I, even for one moment I felt that I need an Endovac system or I need an PIP system. She is so thorough in whatever she is doing currently. Maybe if tomorrow, maybe if she is having an Endovac, her the treatment time uh, might be reduced. But whatever treatment protocol that she is following, the techniques that she is using, the latest treatments, the latest instrument that she is using, she is properly making use of everything. And seriously, she is doing very good job, very good job. I'll share with you my case in the end. Briefly I will share with you what had happened, then you will be able to know what I'm saying about. The fourth question, does Dr. Preeti do good obturation, and whether there are any worries about under and over obturation? So for lasers, obturation is nothing but filling your teeth. That is the last step of your RCT. Second last step, you can say. Second last is your obturation, and then crown cutting takes place, and then crown is fitted. So second last step, you can say, is your obturation. So basically here also many dentists goof up. And why this is a very important step. If you are doing an under or over obturation, both can cause the problem. In under obturation cases, that is, let's say this is the canal. Again, I'm placing the finger for your ease of understanding. Let's say this is the opening, this is the end point, apex. If you are feeling, after you are thoroughly cleaned, all the infection, all the things are removed, all the infection is gone. Okay, so before touching this topic, when to do an obturation. And for the lay users, obturation is done only when you feel that there is absolutely no pain in your canals. The canal shouldn't be weeping, it should be completely dry canal, and there shouldn't be any pain or any signs of any inflammation or infection inside your canal. There shouldn't be any sensitivities as well. If there is any sensitivity, please tell your doctor. If there is any pain, please tell your doctor before obturating. If there is anything unusual that you are observing, please tell your dentist before doing an obturation. Because in obturation, what happens is GP points, that is gatapacha points, are placed inside your canal, and then sealing is done, temporary sealing is done on your tooth. So it's basically, that is, the GP points are filled inside the root canals. And why it is done? So basically, so that you don't get again reinfected. You can't keep the canals empty. If you keep the canals empty, tooth sensitivity problems again begin. You have to fill that canal. In the root canal, what we do is, the pulp is removed from the pulp chamber, and to fill that portion, that empty portion, you can't keep that portion empty. The biggest drawback of doing an under obturation is, let's say your GP point is till this point only. Here, till here, the point is all empty, everything is empty. So this empty again leads to reinfection, and that reinfection will again cause pain. And once that starts, all the procedure that you have done till now will have to be repeated again. That is, the new crown that you had placed will have to be removed, GP points will have to be removed, all the thorough again from stage 1 you have to do sodium hypochlorite rinsing, intercanal medications, all the things you have to again repeat. So that's the reason basically for which you have to take care that there is no under obturation. Again, how will the dentist know that there is no obturation? Again, you can confirm it through apex locator, as well as you can reconfirm it radiographically by taking an x-ray to see that till the apex the GP points are placed properly or no. So regarding Dr. Preeti, she does uses this one apex locator, as well as she radiographically also confirms. So there is no question of having under obturation or over obturation. She does precisely what is required. She doesn't do any over obturation also. So 10 times, before doing 10 times, she has confirmed, and she makes sure that she has confirmed everything, and then only the proper obturation takes place. So don't worry regarding this. So the last question for the doctors will be, which crown does she use after the obturation, and what are the different types of crowns that are available with Dr. Preeti, and worldwide what are the crowns available worldwide. If I go with the worldwide, currently what is being used mostly, the fad you can say, is having a biocompatible material. In biocompatible material, you have zirconia and emax, that is lithium disilicate. So these two are biocompatible materials, and then comes in the lower part is more cheaper part is more cheaper crowns are PFM crowns, which is porcelain fitted metals, in which what happens is one metal crown is there, on the top of the metal crown there is a porcelain or ceramic cap that is fitted. And here also in India I have seen the doctors, when the patient insists of having a ceramic cap, they are actually giving PFM crowns. Can you believe it? They are actually giving PFM crowns, showing the PFM crowns to the patients, saying that this is ceramic, and the patient gets fooled completely gets fooled, because the crown also looks like a ceramic crown, but if you just rotate the crown on the back side, you will see the metal filling, right? So if the person how to identify between proper ceramic, fully ceramic crowns of zirconia and PFM crowns that is fully zirconia crowns are totally fully ceramic. There isn't any material, any metal inside it. While in PFM crowns, you will see the porcelain that is ceramic, you will see on the top of it, and on the bottom you will see in metal. And once when the metal, that PFM crown is fit into your tooth, at that time, how to identify whether the cap that is fitted to me is zirconia or PFM crown? One best technique is just open your mouth wherever the crown is placed and see whether you find a black lining over there, over the gingiva, that is gum lining. If you are seeing a black lining on the gingiva, that is your gum lining, then you can be sure that it's an PFM crown, that is porcelain metal fitted crown. That is the drawback of having a porcelain fitted crown. It does leave that black mark whenever it is fitted. Quickly it doesn't give black mark, but later on it does give the black mark, and it doesn't look good. And basically for those people who have a metal allergy, or who are not willing to put any metal thing inside their mouth, for them the best material that is available currently all over the world, I'm saying, is your zirconia and lithium, that is emax, that is lithium disilicate crowns that are available. So if you do the gradation, the lowest will be PFM, then will be zirconia, and then the highest quality will be emax, that is lithium disilicate. And the difference between all the three is translucency. The last one I won't be talking about, because I'm not in favor of doing this PFM. If unless and until there is there is cost restriction, where the patient can't bear the cost of having a zirconia crown, only in those cases go for PFM crowns. In other cases, if you are able to spend, then it's best to go for a biocompatible material, so that you don't have any problems later on. Later on, like autoimmune diseases, if the patient is having, and he is having a metal allergy, then you had it. PFM crowns is going to create an havoc in your body. this doesn't this doesn't mean that all the PFM crowns are bad. For those healthy persons, who are healthy individuals, who doesn't have any medical history, who doesn't have any metal allergy, and who wants to go for an PFM crowns, they can absolutely don't have any objection regarding that. They can absolutely go forward for this. I am only concerned regarding those class of individuals who are having a metal allergy, known metal allergy, or who are somewhat reacting to to any kind of metal in their body. For those people, please be careful what you put inside your mouth. Choose either zirconia or lithium disilicate, that is emax. And the difference between zirconia and emax is basically translucency and greater aesthetics. Zirconia crowns are more stronger, emax crowns are less durable in that sense. But nowadays even emax crowns are having greater tensile strength. For that you have to pay more, obviously. And then you are also getting the long lasting certificates if you are going for 3M crowns of zirconia. Then there are three different categories there. One is 5 years, one is providing 5 years warranty, one is providing 10 years warranty, one is providing 15 years warranty. So you can choose whichever you want, depending upon your budget you can choose. Then there is monolithic crowns, and then there is layered crowns. So what is the difference between them? This is a separate video. I will make a separate video regarding that, but both the things are also available with Dr. Preeti. You can ask with her which is the best suited crown for you, and decide what you want to go for it. In monolithics are more sturdy, layered are little bit, there is risk of having chip ups in layered crown. So monolithics is better. In zirconia, it's having a greater sturdiness. And regarding translucency, nowadays 3M lava premium, I guess, if you go for a 3M lava premium, it's having 15 years of warranty. As well as there are the translucency is very high in it. Translucency is very high. It's almost as comparable to your Emax crowns, so that you can check it out if you want. So this concludes all the questions regarding doctors, and then I will quickly run over to the second part of the video, which will be on the queries addressing the laypersons. So the first question that we get for the laypersons is, why should I pay more for doing an RCT with Dr. Preeti or some other persons, or if my local dentist is providing me the same RCT treatment at half the cost, why should I pay more? This is the question that almost all doctors face daily, that how do you justify the premium that you ask for your patients. And the answer for this is very, very, very simple. The third question that I had answered, what are the different irrigation techniques that are that your doctor uses, it depends upon that. Seriously saying, the techniques, the be it sonic or ultrasonic or apex locators, or using endovac or using pips, these are really costly instruments, and your local dentist won't be even using these kinds of high-end instruments. If they are not using these high-end instruments, obviously their cost will be low. The persons who are providing you these high-end instruments and doing exactly proper treatments for your tooth, which is having a long-lasting effect, they might charge little bit of premium, but it's the money that is really well paid, and it's value for money, I will say. The simple reason I will tell you, if you go to a local dentist who does the same RCT in half the cost, is not using the instruments that I mentioned prior in the point number 3, the question number 3 that I answered, in those cases the RCT, the success rate of the RCT is hardly 1 to 2 years, 3 years. If within 3 years or within 4 years, if you start to complain again, then that RCT treatment is total failure. That RCT treatment is total failure. Then you have to do again the RCT, and again you have to incur all the costs. Again I said, doing re-RCT is more costlier than doing the RCT at the first time. If you are doing an RCT, proper RCT, that RCT should last 10 years. If you are using proper crown, let's say if you are using zirconia crown, or let's say if you are using Emax crown, even for PFM crowns also, they also last for 15 years also. I've seen PFM crowns last 15 years also. It depends upon patient compliance, how well the patient is cleaning the tooth, how well the patient is taking care of his tooth. It depends upon that also. So hygiene part is there also. So basically, if you are doing it properly, then you are covered for next 10, 15, 20, even 25 years also, if you are doing a proper RCT. So that is the huge difference and huge advantage that you get for using these high-end instruments. And this is the basically where you can justify the premium that you are charging. So I answered your first question. The next question is which all laypersons will ask, whether it pains doing the RCT and whether there are any pains post RCT treatment. This is a very big question. I will better post a separate video for this question, because there are many things to consider in this, and I will be telling the names of the medicines also. So I want a separate video on that. I will be posting a separate video regarding that question. The third question is, uh, Dr. Preeti uses microscope while doing RCT, while local doctor doesn't do the microscopic RCT. So what is the difference between these two? Is using microscope while doing RCT really needed in all cases, or is it only needed in cavity cases or fracture cases? Is microscopic RCT just a marketing gimmick, or does it really have any benefits? Okay, this is a very good question, which not many tackle or like to tackle. The reason being simple: microscopic RCT, there are very few doctors, be it in India or be it in world also, who are practicing microscopic dentistry. Microscopic is an latest protocol. Latest, you can't say protocol, but latest evaluation you can say. Evaluation you can say in dentistry, which is revolutionizing the dentistry, the field of the dentistry, and even the field where you're doing an endodontic treatment on the patients, or even the basic reason for being the success rate which gets shoots up when you're doing this microscopic RCT. The reason being, in microscopic RCT you are able to zoom up to 400 to 600 depending upon what type of microscope the person is using, and because of that you are able to even minutely observe everything that is taking place inside your canal. So the cleaning that takes place by using the microscopic RCT is next level, even in scaling also. And this is not a marketing gimmick. Just take that fad out, that microscopic RCT is just a marketing gimmick. It's not. I have seen the difference. I have felt the difference. Even small things also get cleared exactly. Doing microscopic RCT is not joke. Hardly in Pune, hardly there are 5 to 7 doctors only doing microscopic RCT, and the charges for doing the microscopic RCT is almost double from the normal charges that you pay. Seriously, but the difference that it makes while doing the treatment is absolutely great. You can make it out. You can make it out the difference. RCT is also used during the cavity cases, also during the fracture cases also, and even in the regular RCTs also. Let's say you have done the BMP on the patients. You have done the BMP. Infection is gone. You can properly see whether the canals is till the apex. You can see properly by doing zoom. Whether everything is cleaned or not. That is the most critical thing in this doing the root canal. To clean the RCT and make sure that there is absolutely no residual, no soft tissue left inside the canal. So this thing she does, and absolutely even in scaling cases also she does use microscope, and you can clearly tell the difference. Even the nooks and corners of the cleaning takes place by the microscope, and the results are absolutely wonderful. You'll be thrilled to know. Over the top of doing scaling, you can also go for zoom whitening. So that is another latest thing that you can go for. So overall, if I have to rate her, Dr. Preeti, that the treatment that I had taken from her for the RCT or beads for scaling, or even I had taken fillings also, out of 10 I would definitely give 10 out of 10. She is doing everything at par with what is happening in West, in and the treatment protocols that she is following are latest. As I told you, only thing missing is endovac and pips that I honestly shared with you. Maybe this can be one of the scope of improvement, maybe in later stages you can have endovac or pips also with her. That being said, whatever things that are at present with her, she is doing excellent, and I will share with you my case in the next video. Both the cases I'll tell you. Okay. Regarding one case I can share with you right now. um, let's say this is first quadrant, this is second quadrant, this is third quadrant, this is fourth quadrant. 1 2 3 4. I am using FDI naming system, in which first quadrant is 1, second quadrant is 2, third quadrant is 3, this is fourth. Each quadrant contains 8 tooths. So if I say 1 8, that means first quadrant 1 and 8 is 8 number tooth. The tooth numbering starts from here, 1 2 3 4 5 6 7. If I say 1 8, so that means it's first quadrant 8 number tooth. Right now I am saying 3 6. 3 6 means it's third quadrant and sixth number tooth from here. So mine was an accident case, and I do have an bruxism habit also. So both the things coupled together had fractured my 3 6 number tooth from here, and the food slipped through that fractured tooth inside, causing a decay in the root canal. And the decay was so severe that not only one tooth but both the tooths had been impacted, 3 5 and 3 6. But major pain was on 3 6. We did an CBCT report in which fracture was not seen. Okay. In CBCT also fractures were, in some cases fractures are not seen, which are not visible. But in microscopic RCT, when you're doing in the microscope, you're able to perfectly see the fracture line. Even smallest of the fracture lines you're able to see. So that is really good thing. And so what she started doing BMP on 3 6, entire treatment was done, and automatically all the pain that was there on 3 5 also vanished. I had gone to another endodontist, most famous endodontist of Pune. I had gone, and she had told me that 3 5 and 3 6 both the tooth need to be opened, and the treatment protocol will last for 1 month. To Dr. Preeti then I went. She told that 3 5 is not needed, only 3 6 is needed. We will go for 3 6 first, and let's see what the results we get. If it gets healed, then there is absolutely no need for opening 3 5. And that is what happened. She properly treated me with 3 6 number tooth, cleared all the infection, and surprisingly I did post RCT treatment 1.5 months after the RCT. I did CBCT again to confirm whether the infection has gone or no, and you'll be surprised to know 3 6 was also gone and 3 5 was also gone, radiographically as well as symptomatically also. Totally gone, no pain at all. Only one tooth opening was required, that is 3 6, and she was doing great. I won't hesitate even one bit for recommending her for any treatment whatsoever. But there is one caveat also. Please watch my video in which I will be sharing with you what all medicines to be taken for post-traumatic, for post RCT pains. That is a big topic and very important topic. So please watch out for that video. I will be sharing with you again here also. I will be sticking to same thing. I will be sharing with you latest protocol here also, and then I will be telling you the names of the medicines that needs to be taken also. So both the things I will be combining and sharing with you all my experience. Thanks for now. Thanks for watching till end. Thank you. Please do subscribe, like and share this video. And if you feel, and this is the request for the doctors, if you felt that you gained something or you learned something new from watching this video, please do mention it in comments and let me know what was the new thing that you personally enjoyed watching this, and what was your takeaway by seeing this video. Let me know your feedback. Thank you.